Good morning, dear professors and colleagues. First of all, I want to thank the organizing committee, for, especially Dr. Aida, for invitation. I will talk about the diagnostic approach in pediatric liver masses. Liver lesions account for 5 to 6% of all intra-abdominal masses in children. A variety of focal liver lesions are seen in pediatric liver, including neoplastic, whether benign or malignant, congenital, regenerative, or infectious lesions. Malignant liver tumors account for only 1.3% of all childhood cancer, but they constitute, unfortunately, for 2/3 of all pediatric liver tumors. Almost 90% of pediatric malignancies are primary hepatic tumors, with the remaining 10% of being metastases. Hepatoblastoma is the most common malignancy, accounting for 67% of the cases, followed by hepatocellular carcinoma, accounting for 31%. Other rare malignancies include embryonal sarcoma, account for only 2% of the cases. Benign lesions that account for the remaining 1/3 of the liver lesions include hemangioma, mesenchymal hamartoma, FNH, regenerative nodules, hepatocellular adenoma. This is the long list of the possible lesions in the pediatric liver, including malignant neoplasms. As we said, the common hepatoblastoma, HCC, or undifferentiated embryonal sarcoma, benign lesions, infectious lesions, and vascular or traumatic lesions. While some lesions are seen in pediatric liver, in the pediatric liver are also found in the adults, others are found exclusively in children, for example, the infantile congenital hemangioma, hepatoblastoma, or mesenchymal hamartoma. They present by abdominal distension, pain, palpable mass, hepatomegaly, incidental detection at imaging performed for other reasons. And the differential diagnosis is based upon the patient's age, clinical presentation, and the serum alpha-fetoprotein, which is very essential in the diagnosis and helps to guide the initial workup. Usually we start with ultrasound in patients with suspected mass. It is useful for detection and confirming the origin of the mass and guiding the possible and the subsequent imaging examination. Once the hepatic lesion is confirmed, multiphasic contrast enhanced MRI is recommended for most of the lesions as the next imaging modality, allowing full characterization and assessment of the liver parenchyma. If it is not available or not feasible, contrast-enhanced CT can be also performed in assessment of pediatric focal lesions, and those having a contraindication also to MRI. This is the most important slide. The multiphasic CT in children does not need to be 3 or 4 phases like the adult. We omit the non-contrast phase, and it is usually 2 phases. Late arterial phase performed only on the liver, and a portal venous phase covering the entire abdomen and the pelvis. A third phase, a delayed phase, is added only in patients with suspected HCC, pediatric patients suspected HCC as age more than 10 years old, or known patients with chronic liver disease. So please modify the triphasic protocol for imaging of pediatric patients. PET and other nuclear medicine imaging techniques have a little role in the initial assessment of focal liver lesions. Starting by focal lesions in the neonate, hepatic lesions commonly encountered in this age group include congenital and infantile hemangioma, the hepatoblastoma, and metastases typically from neuroblastoma. The infantile hemangioma are not present at birth, rather they develop over the first weeks to months of life. Infants with multiple cutaneous hemangiomas are more likely to have internal hemangiomas, and the liver is the most common organ affected. This is an ultrasound performed for a 3-month-old girl showing multiple hypoechoic lesions that was suggested to be a liver hemangiomas. And at the age of 11 months, there's a typical natural history of this hemangioma is the complete resolution. Note the hemangiomas, the infantile hemangiomas, in contrast to adult hemangiomas, they appear on the ultrasound hypoechoic, not hyperechoic. A multiphasic MRI shows a dynamic MRI shows the typical appearance. Here the ultrasound shows heterogeneous echogenic liver mass. On axial T2 fat sat, this is a typical T2 hyperintense signal with peripheral rim enhancement with gradual centripetal enhancement characteristic for infantile or congenital hemangioma. This is an ultrasound performed at the age of 14 months, and then at the age of 10 years shows the natural history of the hemangioma, which is the regression and resolution. Focal lesions encountered in small children aging from 6 months to 6 years. Again, hepatoblastoma and hemangioma are the dominant causes of newly diagnosed liver mass. Other liver tumors rare in this age group includes the mesenchymal hamartoma and the biliary rhabdomyosarcoma. Hepatoblastoma is the most common primary malignant tumor in children under the age of 40 years, usually present with a painless abdominal mass with raised alpha-fetoprotein in 90% of the cases. And the hepatoblastoma is considered one of the embryonic tumor. On ultrasound, it appears as a well-defined heterogeneous or hyperechoic mass. We may see calcification within. On CT, it appears as a well-defined hypo-enhancing or heterogeneously enhancing mass with areas of hemorrhage or necrosis. Also, calcification can be seen in 40% of the cases. This is a dynamic MRI, shows the heterogeneous signal on T2. On the T1, this is the arterial phase T1 post-contrast, shows the heterogeneous hypo-enhancing mass in relation to the liver parenchyma and the arterial and the venous and the delayed. And this is a case from the literature, injected with a hepatospecific agent, showing the lack of contrast retention by the hepatoblastoma, which is a characteristic for hepatoblastoma, and the hepatospecific agents. Unfortunately, this type of contrast is unavailable in Egypt. It's important in the case of a hepatoblastoma, you should write a pretext staging. What is a pretext staging? It is abbreviation for a pre-treatment extent of the tumor. This system has been the primary method for risk stratification for hepatoblastoma and pediatric HCC in numerous cooperative group trials. It is made of two components, pretext group and pretext factor. The pretext group describes the extent of the tumor within the liver. The annotation factor, it includes the vascular involvement, whether portal vein or the IVC or the hepatic veins, the presence of extrahepatic disease, multifocality, caudate involvement, tumor rupture, and the presence of metastasis, whether lung or lymph nodes. In the pretext, they divide the liver into sections. The 4 sections. The first section is the left lateral section, which includes segments 2 and 3. The left medial section, which includes 4A and 4B. The right anterior section includes 5 and 8. And the right posterior, which includes 6 and 7, segments 6 and 7. Pretext 1 involves 1 section with 3 contiguous free hepatic sections. So the only scenario that applies to pretext 1, it is either left lateral or right posterior. Pretext 2, 2 contiguous sections. Any 2 contiguous sections are spared is considered as pretext 2. If it is present only in the caudate, it will be considered as a pretext 2. Pretext 3, 1 section of the tumor is free. A pretext 4, which is essentially an infiltrative form of hepatoblastoma or a multifocal hepatoblastoma, it includes all 4 sections. This is an example for the structured report, and we use in reporting a case of a hepatoblastoma. You should write the comment about the background liver parenchyma, the liver lesion, comment on the pretext group, the sections involved, and all the annotation factors should be written, whether positive or negative. The V and the P, the extrahepatic disease, the multifocality, all should be considered in order to manage this case, because the chemotherapy will depend upon the pretext group. Mesenchymal hamartoma is a benign hepatic lesion which is exceedingly rare, typically diagnosed in very young children, with 80% diagnosed before the age of 2 years, 95% diagnosed before the age of 5 years, and classically present with a normal serum alpha-fetoprotein, which is important differential from hepatoblastoma. Usually, the classic presentation is a cystic mass with a variable amount of associated soft tissue. The classic appearance is a multi-septated cystic mass in a young child. It would be the first differential is a mesenchymal hamartoma. However, it could present as a completely solid mass, and then it couldn't be differentiated from a hepatoblastoma. Usually, they are often resected because of its large size and the overlapping features with hepatoblastoma and the potential to de-differentiate into embryonal sarcoma. This is a case from Burj Al Arab Pediatric Oncology Center. This is a 7-year-old girl presented by an incidentally discovered liver mass on ultrasound, a contrast enhanced CT, multiphasic CT liver performed, showing a complex cystic mass with predominant cystic component and soft tissue component. Well, the differential for this case was first hydatid disease that was excluded by the serologic study and by a core biopsy that revealed a neoplastic tissue. So the decision in the MDT was to upfront surgery, and this was a case of mesenchymal hamartoma, as was suggested. But unfortunately, an on-top embryonal sarcoma was found in the pathology specimen. So focal lesions in older, moving to the focal lesions in older age children, typically more than 10 years. The most common malignant tumor in those children is HCC, hepatocellular carcinoma, including the conventional and the fibrolamellar types. Other malignancies encountered in this age group is the hepatocellular malignant neoplasm, not otherwise specified, or undifferentiated embryonal sarcoma. Benign tumors like in the adult FNH, hepatocellular adenoma, regenerative or dysplastic nodules on top of chronic liver disease. This is a typical case of FNH, with the ultrasound shows the characteristic spoke wheel vascularity. On the T2 shows hypointense signal with a T2 hyperintense signal of the scar. On the arterial phase, it shows avid enhancement with progressive fading and iso enhancement on the delayed phase. With hepatospecific agents, it shows retention of the contrast, denoting the functioning hepatocytes. This is a case of pediatric HCC with a characteristic enhancement similar to the adult, with arterial hyperenhancement and washout in the venous or the delayed phases. Children with history of malignancy, they can develop multiple types of hepatic lesions at various stages, infections during the immunocompromised state, manifesting as focal lesions or metastases. This is a case of candidiasis with a typical appearance on the ultrasound, targetoid appearance or the bullseye appearance, central echogenicity and central echogenicity with peripheral hypoechogenicity, and again the characteristic appearance on the contrast enhanced CT. And if you find these lesions in the liver and the spleen, you can confidently diagnose this case as hepatosplenic candidiasis in a patient with febrile neutropenia. We should note that the LIRADS is the liver imaging and reporting data system used developed by the ACR to screen for HCC in adults cannot be used in pediatric patients less than 18 years old. Hence, lesions with suspicious lesions characteristics on CT or MRI should be always biopsied. The last version of the LIRADS was in 2018. In 2020, the ACR developed a consensus for pediatric liver lesions called the pediatric hepatoblastoma and hepatocellular carcinoma with a diagram illustrating the common pediatric liver lesions. The diagram for both CT and MRI that is recommended to read and to review in a case of pediatric liver lesions. So to conclude, imaging plays an important role in the diagnosis and management of focal liver lesions, helping to avoid the use of invasive biopsy in many instances. Ultrasound is the initial screening tool. Dynamic MRI is the preferred next imaging modality. Multiphasic CT is a two-phase only in pediatric protocol, only arterial and venous. It is essential to include a pretext staging in reporting hepatoblastoma and pediatric HCC. Thank you.
دكتورة هبة من فضلك. ميرسي على المحاضرة الجميلة. أنا عندي سؤالين. السؤال الأولاني حضرتك ذكرتي اسم سنتر اسمه برج العرب أونكولوجي سنتر تبع إيه؟ جامعة اسكندرية. طيب السؤال الثاني ميرسي طبعا. السؤال الثاني آخر حالة أو آخر جزء أنت قلتيه اللي هو الكانديديزيس. اوكي اللي هو اوكي دلوقتي انا غالبا الكانديديز بتيجي في الاطفال طبعا تشخيص دايركت على طول بالالتراساوند زي ما انت ذكرتي وممكن تكونفيرم بس في اطفال اللي بيجي لهم اساسا كانديديز بيبقوا اساسا يونو كومبرومايزد ممكن يكون لوكيميك ممكن يكون ليمفوما وبياخد كيموثيرابي بالظبط ده اللي بيحصل له سكندري ليه انه يحصل له هقدر افرق ازاي بقى ساعتها ان هي كانديديز مش ميتاستاسيس
لو لقيت الليجنز دي في الليفر والسبلين في هيستوري patient immunocompromised febrile neutropenia زي ما حضرتك ذكرتي في لوكيميا او ليمفوما it is a characteristic يعني characteristic.
طب ليه مش انفلتريشن؟ انا بسأل ليه مش انفلتريشن من اللوكيميا او من الليمفوما حتى لو واخده شكل مختلف؟
يعني بتبقى multiple tiny innumerable lesions
انا عايزك تشرحي لهم.
ايوه وبتبقى characteristic targetoid او bull eye appearance على الالتراساوند والسيتي والpresence الconcomitant presence in both liver and spleen it's diagnostic for hepatosplenic
بينما الانفلتريشنز سواء كانت ليمفوما ليها شكل مختلف واللوكيميك ليها شكل مختلف بالزبط. يعني دايما الانفلتريشن بتاعت الليمفوما تحب تبقى هايبوكويك سودا بينما يعني كلام جنرال طبعا بينما اللوكيميك تحب تبقى بالعكس ايكوجينيك فانا قصدي بس ان انت كنت يعني الموضوع ده فيري كومن هو نادر قوي ان احنا نشوف طفل يحصل له فانجس من غير ما يكون هو اساسا اميونو كومبرومايز بس ممكن من ضمن الاميونو كومبرومايز يكون مثلا لا قدر الله ايدز او بياخد كورتيكوستيرويدز او حاجه لكن مش شرط يكون لوكيميك او ليمفوما بس لو هو في حاله لوكيميك او ليمفوما لازم يبقى نبذل مجهود شويه ونتاكد ان دي لانه لو خد علاج ده هيخف تماما بينما لو هو حاجه انفلتريشن هنخش في قصه ثانيه خالص.
انا كومنلي بشوفها عشان انا بشتغل في بيدياتريك اونكولوجي سنتر it's a common scenario and
ميرسي دكتوره هبه على المحاضره الجميله. ميرسي يا حبيبتي.